Hello everybody, I'm Michael Bates, and it's my pleasure today to welcome Professor Art Reingold, who's going to be talking to us about screening, about which he's an expert. So welcome, Art.
Thank you very much. I'm very happy to be here.
So perhaps we could start by having you define screening.
I'll be happy to. Screening is a very, very important issue in public health and in clinical medicine. It's one of those areas that the two fields actually have to collaborate on. And as defined many years ago, screening is the presumptive identification of undiagnosed illness, disease, or defect by the application of tests to a generally asymptomatic population. So what we're doing is we are taking a healthy population, or a population who don't have signs or symptoms of a condition, and applying a presumptive initial test of some kind, a blood test, a urine test, a radiographic procedure, to see whether they have evidence of a particular condition. But what's important is that screening tests are not intended to be diagnostic. So if you have a positive screening test, the implication is that there are then follow-up tests or procedures that have to be done to determine whether you truly have the condition or not.
So I understand there's an important distinction between screening and testing.
Well, to me, it's an important distinction. I think much of the world has lost sight of the difference and now frequently uses the word screening when what they really mean is testing. So if you look at various types of programs as recommended by public health agencies or clinical groups, they refer to screening of blood pressure, of diabetes, of inborn errors of metabolism, of birth defects, different types of infection like HIV. Some of these are screening programs, as I defined them. Some of them really are testing programs. And perhaps I'll just give this as an example. This is the request from the California Department of Public Health that all pregnant women should be tested for hepatitis B virus because we want to make sure that there is not transmission from mother to baby. This is a very important public health program, but this really is testing. A woman either has hepatitis B surface antigen positivity or she doesn't. So this is referred to by many as screening, but this is really a testing program. The same thing is true when the internal medicine group that makes recommendations talks about screening for obesity when a patient comes into the office. What they really mean is you should take the patient's weight and height, perhaps calculate their body mass index, and determine whether they're obese or not. There really is no subsequent test which is done to confirm the diagnosis of screening. And here again, the issue of testing children for cholesterol. This is not really screening, this is testing. So why might we want to screen a population for a condition? Well, the primary purpose in many instances is to try and reduce or prevent mortality. And many people will be familiar with screening for cervical cancer or for breast cancer, where clearly the intention is to try and prevent mortality from those conditions. But you could also, in theory, by screening, potentially reduce morbidity. You could potentially extend survival, and you could potentially reduce healthcare costs, all of which are potentially beneficial outcomes of screening, even if it can be difficult to prove that screening leads to those improvements. The World Health Organization, as you know, has defined a number of criteria that make a condition worthy of screening for, and they're listed here, but fundamentally what we want is conditions that are important from the point of view of morbidity and mortality, number one. Number two, that the natural history of the disease allows us the opportunity to detect illness or abnormalities in a preclinical, early in the phase of the illness, and for which there is an effective treatment that gives us a better outcome early on. And then there are some characteristics of screening tests that are shown here that I want to then talk about in terms of the attributes of a test. So what's portrayed here is this idea of the natural history of a condition. And basically the idea here is that you have one person who is going along in his or her life At point A in his or her life, there's the biological onset of a condition, let's say breast cancer. So at point A, a woman has biological breast cancer, but ordinarily in the absence of symptoms, in the absence rather of screening, she would go along and eventually develop symptoms. And that's at point C. And left untreated, or potentially if treatment fails, she would die of the breast cancer at some subsequent point. And the idea here is that somewhere between point A and point C, between biological onset and development of symptoms, there is the disease becomes detectable by the application of a screening test. And so if this is true for a condition, then the condition might be amenable and appropriate for screening. That is, there's a detectable preclinical phase in the natural history of the disease.
So, what are some of the reasons that you would carry out screening? I mean, what sort of conditions are the ones that would most justify screening?
Well, using the strict definition of screening, for the most part, these have been cancers. And clearly, our most successful screening programs currently in wealthy countries are screening programs for cervical cancer, screening programs for breast cancer, although there is some controversy around screening for breast cancer. There is a great deal of screening going on for prostate cancer, although there is also a lot of controversy about whether that's an effective tool or not. And quite recently, we now have good data showing that one particular test in very high-risk individuals might be an appropriate screening test for lung cancer. And this is in very heavy smokers with a long history of smoking. There is now one radiographic procedure which does appear to meet the criteria for being a good screening test.
So it's mainly serious disease?
Yes. So we generally are not going to screen an individual for something that's relatively minor. One of the criteria for screening is that it be a serious disease, and that's in part to justify the expense. When you take a test and apply it to millions or tens or hundreds of millions of people, this adds up to a lot of money. It can be billions of dollars spent to screen large numbers of people. So we wouldn't want to do that for something which is relatively trivial or unimportant in terms of the seriousness of the illness. And the other reason is there are some downsides to screening. There are risks associated with screening, exposure to radiation, for example. There is the follow-up that occurs, perhaps a biopsy, and there's morbidity and even rarely mortality sometimes associated with the follow-up. So we want to tip the balance between the advantages of early detection and the disadvantages that come with application of tests to large numbers of people who are asymptomatic. And again, this is basically demonstrated here that, as I've said, we do have what we now consider to be effective screening tools for cervical cancer and for breast cancer. This slide really should be updated a little bit because just within the last couple of months, we now have evidence that we have a good screening test for lung cancer in very heavy smokers. On the other hand, screening for something like non-melanoma skin cancer would not be, as far as we can tell, a useful public health or clinical strategy. That is to say, as opposed to simply waiting for patients to come in or for their physicians to notice something on the skin. There really would be no particular advantage. And as I've indicated here, we do sometimes test large populations. Again, many people call it screening for infectious agents. And here the primary interest is in preventing transmission to other individuals, so mother-to-child transmission of HIV or hepatitis B, or potentially transmission to a sexual partner or someone else. So detecting asymptomatic infection to prevent transmission. And of course, we do screening in a variety of settings. So anyone who walks into a drugstore knows that you can take your blood pressure while you're waiting for your prescription to be filled in many places. So screening can take place in shopping centers and drugstores. It certainly occurs in primary care settings and in hospitals. So screening really can be done in a variety of different places.
So can you tell us something about how we interpret the results of screening tests?
So that brings us to the attributes of screening that I think are absolutely vital for anyone in epidemiology or public health to be familiar with. And so there are 4 attributes that we can calculate about a screening test. They're the sensitivity, the specificity, the predictive value of a positive test, and the predictive value of a negative test. And each of these has a definition, and I think it's better if I first give a definition and then illustrate this with some data. So the formal definition of a test sensitivity is the probability of testing positive if the disease is truly present. In other words, of all the people who have the condition, what proportion will have a positive test? And that can range from 0 to 100%. And we, of course, would like a very sensitive test with 100% sensitivity if possible. Clearly, as the sensitivity increases, the number of false negatives will decrease, and we'd like to have as few false negatives as possible. The specificity is the probability of testing negative if the disease is truly absent. So of all the people who don't have the condition, what proportion will have a negative test? Again, the range of that is anywhere from 0 to 100%. We would like a test with 100% specificity. And as the specificity goes up, the number of false positives that we will generate will go down. And of course, we want as few false positives as possible. The problem is that in general, for virtually every test, anything we do to increase sensitivity decreases specificity, and anything we do to increase specificity decreases sensitivity. So we have to make a choice.
Right, so how do we optimize those, sensitivity and specificity?
Well, in some instances, people use what's called a receiver operator characteristic, or an ROC curve. This is a concept that actually comes out of industry in terms of looking at quality of products and things of that kind, and success or failure in the manufacturing processes. But basically, as displayed here, on the y-axis you have the sensitivity of the test, and on the x-axis you have 1 minus the specificity. And many tests, in this case it's a prostate-specific antigen test for prostate cancer, you actually generate a number on a continuous scale, and you have to decide what cutoff to use to declare a positive test. So 4 nanograms per milliliter, or 2.5 nanograms, or something like that.
So this particular curve here, doesn't have a very sharp point of inflection, so it might be difficult, arguable, where the optimal point was, perhaps.
So what we are looking for in generating these curves, as you said, is a point of inflection. In other words, ideally, we would like to find a point where the curve goes up very quickly and then tapers off going this way, and the point of inflection would be the point at which it levels off. And that would give us the maximum combination of sensitivity and specificity. But when they go up gradually, as shown in this curve, frankly, it's arbitrary at what point you declare the cutoff to be a positive or a negative test.
Right.
And that then gives you a set of sensitivity and specificity that is not perfect for either. Mm-hmm. Now, as I've said, the other 2 important attributes that people need to be familiar with are the predictive values of a test. The predictive value of a positive, or the positive predictive value, is the probability of the disease being present if the test is positive. So in other words, of all the people who have a positive test, what proportion truly have the disease? Again, it can range from 0 to 100%, and again, we would like it as close to 100% as possible, because people who have a positive test and don't have the disease, false positives, typically have a lot of follow-up testing to do, and the morbidity, the mortality, the emotional distress that can come with that. The predictive value of a negative is the probability of the disease being absent if the test is negative. I think these can best be displayed.
I just ask first, which of these 2 is the most useful?
Well, in most settings in a screening program, the positive predictive value, or the predictive value of a positive, is far and away the most important thing to look at, because for the most part, the predictive value of a negative is almost invariably very, very high, 99% or greater. And so it's very unusual that we have to worry about the predictive value of a negative. But we do often have to worry about the predictive value of a positive, as I'll show you. Of course, epidemiologists frequently think in 2x2 tables, as you know. And what this 2x2 table shows is basically it's illustrating these concepts of sensitivity, specificity, and then positive and negative predictive values. And so the idea here is that we would apply a test to a population, and we're going to classify people into 4 groups. Group A in this table are the people who have the condition we're screening for, let's say breast cancer, and who have a positive screening test. Group B are the people who don't have breast cancer, but who still nevertheless have a positive test. Group C are the people who have breast cancer, but have a negative test. And Group D are the people who don't have the disease and also have a negative test. So Group A are the true positives. Group B are the false positives. Group C are the false negatives. And Group D are the true negatives. And with these 4, you can then calculate these 4 characteristics. Now the problem is, I have it listed here as what does God see, if God could tell us the truth about patients, but we need a gold standard against which to compare the screening test.
Of course.
So as it shows here, the sensitivity in this table is just A over A plus C. The specificity is D over B plus D. The positive predictive value is A over A plus B, and the negative predictive value is D over C plus D. And I'll illustrate this with some numbers. So if we had a population of 1,000 people, and out of those 1,000, 100 have the condition and 900 don't, so in other words, a prevalence of 10%, and we apply this test that I'm just speculating about here. These are not real data. I'll show you some real data in a minute. And if out of the 100 people with the disease, 80 have a positive test and 20 have a negative test, out of the 900 without the disease, 100 have a positive test and 800 have a negative test, then the sensitivity is just 80 over 100 or 80%. The specificity is 800 over 900 or 89%. And then, and I'll show you here, the predictive values. The positive predictive value is 80 over 180 or 44%, and the negative predictive value is 800 over 820 or 98%.
So how are the positive predictive value in particular, I guess, and also the negative predictive value affected by the sensitivity and specificity of the test?
So that's a really important thing for people to be aware of. And so the 2 determinants, the primary determinants of the positive predictive value are the specificity of the test and, very importantly, the prevalence of the condition in the population being screened. And as the prevalence goes up, as I'll show you in a minute, the positive predictive value goes up. As the prevalence goes down, the positive predictive value goes down. The primary determinant of the negative predictive value is the sensitivity of the test. But again, for virtually every screening program we have, the negative predictive value is very, very high, and we don't really have to worry about it. So here are some real data, and these are taken from the very first study of mammography called the HIP study. And this was a study started in the 1960s, mammography that's not representative of the mammography we do today. So I wouldn't want people to think these are the correct characteristics of mammography as done in 2013. But nevertheless, as mammography was done in the 1960s, this study took about 65,000 women, randomly assigned some to screening and others to no screening, so it was a randomized clinical trial. But as shown here, they basically could, among those 65,000 women, ultimately determine that 177 of them had breast cancer and probably had it at the time they were being screened. A little over 64,000 did not have breast cancer. And here you can see the results of their initial screening mammography and physical exam. So out of the 177 women who had breast cancer, the screening test was positive at 132. So the sensitivity is just 132 over 177, or about 75%. The specificity, as you see here, was very high, 98, almost 99%. But importantly, as you'll see then going across, the positive predictive value of mammography is done then. So out of the 1,115 women with a positive mammogram, only 132, or 12%, actually had breast cancer. And the vast majority, the other 88%, were basically false positives.
Of course, that has some important implications for people who
well,
have
and
false positives.
as any woman who's undergone mammography knows, if you have a positive mammogram, of course, then there is follow-up which should be done, and that often involves a biopsy and certainly a great deal of emotional distress. So yes, the follow-up can be quite substantial in terms of the stress associated with it, the cost of it, etc. So that's why a lot of false positives or a low positive predictive value are problematic for a screening program. And here again you can see the positive predictive value of a negative 99.9%, again, as it illustrates the fact that the negative predictive value is almost invariably very, very, very high. Okay. Well, these next couple of slides are simply meant to illustrate the fact that what are the factors that influence particularly the positive predictive value. And so, again, these are some artificial numbers based on a population of 100,000, and here the test has a 90% sensitivity, a 95% specificity, and a prevalence of 1% in the population. I've defined the sensitivity and specificity. You can see as a result in this population with a prevalence of 1%, the positive predictive value is about 15%, similar to what it was for mammography in that early study. Now what the next slide shows is if you increase the specificity from 95% to 98%, but the sensitivity remains the same and the prevalence is the same, you can see the positive predictive value almost doubles. And so again, as the specificity of a test goes up, the positive predictive value goes up.
So most people would probably look at this and say, well, what's the difference between 95 and 98%? It seems on the face of it like a very small change, but it makes such a huge difference to the positive predictive value.
Well, that's right, and that's why when we make a decision about cut points and what sensitivity and specificity we want, we need to think about this issue of where we set the cut points, because even a modest increase in the specificity can give us a substantial increase in the positive predictive value. As important, as I've already said, perhaps in some ways more important, is the effective prevalence. So this is simply showing that taking the same test with a sensitivity of 95% and a specificity of 95%, but applying it to populations in which the prevalence of disease varies, the positive predictive value varies enormously. So, for example, here you can see that in a population where the disease is very, very rare, 0.1% have the condition, very rare condition, the positive predictive value is under 2%, which means that the overwhelming majority, 98% of all the positive tests, are false positives, as opposed to a population where half the population have the condition, a prevalence of 50%, the positive predictive value is 95%. In other words, virtually every positive is a true positive.
So in practice, because we're talking about serious diseases, they really only occur in a small fraction of the population. So we're at the lower end of the prevalence scale.
Well, for many,
instances.
many screening programs, such as breast cancer and prostate cancer and things like that, yes. Well, prostate cancer, let me take that back. For things like breast cancer and cervical cancer, you're right. The prevalence is going to be very low in most populations screened. And unfortunately, what that means is the positive predictive value similarly may be quite low. And again, this relationship between prevalence and the positive predictive value is basically illustrated here in the solid line. As the prevalence goes up, the positive predictive value of the test goes up. And that's really all what this particular slide is meant to illustrate. Now, you then come to the question of, well, if we're having to choose a cutoff, do we want to maximize sensitivity of the test or maximize specificity of the test? And of course, there is no simple answer to that, and there are really a number of value judgments that come into play. Generally, we want to maximize sensitivity when a false negative is a very, very serious problem. So if by failing to detect something, a serious outcome will occur that we really would be a tragedy, we generally want to maximize sensitivity. And while testing newborns for something called phenylketonuria, or PKU, is again for me a testing program, not a screening program, it illustrates this point. Because if you detect an infant who has this genetic defect, you can change their diet and they can live a long, healthy life. If you fail to detect the infant and they are exposed to phenylalanine in their diet, they will become mentally retarded and consigned to a very different life. So we don't want to miss any of these children, and we want a test that has maximal sensitivity.
Makes good sense.
And that would also be true if we were trying to detect infections, where again, failing to detect an infection has really substantial implications for the individual or his or her offspring or contacts. On the other hand, we might have a preference for maximizing specificity when the implications of a positive test are grave. So if the follow-up that we would expect to happen after a positive test involves substantial morbidity and cost and maybe even occasional mortality, then we might want a test that has great specificity. And so one example of that is in the area of prostate cancer, is that the follow-up for a positive PSA test can involve a biopsy, it can involve pretty aggressive treatment. We might want to have a fairly specific test in that instance. Now, this is simply to point out that if we can't get maximal sensitivity and specificity from one test, we can sometimes achieve it by doing two tests, one after the other. We start with a test that has high sensitivity, and then if that's positive, we do a confirmatory test which has much greater specificity. And clinicians in particular are quite familiar with this in the context of testing for things like syphilis or testing for HIV. So we start with a very sensitive test, and if that's positive, we then confirm with a specific test.
So what about the impact of screening on statistics for incidence of some of these diseases?
So I think this is an important issue. Many people are under the mistaken impression that screening might reduce the incidence of disease. There's really only one screening program where that's true, and that I know of, and that's screening for cervical cancer. Because when we screen for cervical cancer, we're actually detecting pre-cancer lesions and treating the woman before she develops cancer of the cervix. So in that instance, the rate of cervical cancer in the population will go down, and the rate of mortality from cervical cancer should go down. But in other instances, and breast cancer is a very good example, by screening, we would actually expect the incidence of the disease to go up. That is, we will detect more breast cancers, and breast cancer screening is not intended to prevent breast cancer. Breast cancer screening is intended to prevent breast cancer mortality or deaths from breast cancer. And this has been seen, so that's really an issue I'll illustrate in perhaps in this next slide. So this just shows that when you begin a screening program, that the incidence in fact goes up. And of course, for the most part, these are very early cancers, and so you're talking about an increase, in this case, in stage 1 breast cancer, very early breast cancer. But the incidence doesn't go down, it goes up. It's mortality that should go down.
So many of these detected breast cancer cases would not actually would not be manifest if there was no screening program later on?
Well, that's a good question. So part of this is, if you will, a speeding up of detection. So the bump in detection, or the increase in rate, may be temporary, and then following that, you would expect the rate to go back down, or to not necessarily remain elevated, because this is an initial phenomenon when you introduce a screening program. The rate might actually go up, however, if you're detecting a number of cancers that otherwise would not ever become clinically evident. And so in the case of prostate cancer, as an example, one of the reasons the incidence of prostate cancer is going up is because of increased detection of cancers that would have been totally asymptomatic and never have caused symptoms in someone before they died of heart disease or some other outcome, a stroke or something like that. So it depends a little bit on which outcome we're talking about, whether the increase in incidence will be sustained or only temporary. Now, I think the other thing to say is that when we evaluate screening effectiveness, that there are studies we should be doing in order to see whether screening works or not. So this slide basically, again, just refers to this idea of the incidence of disease. But if the screening is intended to prevent death, mortality from the outcome, then we should expect to see a decrease in the cause-specific mortality. And so this, again, just illustrates the fact that the increase in breast cancer when we begin screening is primarily in the very early stages of breast cancer. And in fact, as more time passes, you would expect the incidence of more advanced stages of breast cancer potentially to decrease. The rate of early cancers would increase, the rate of later stage cancers would decrease. So if we ask how we then can evaluate how good a job screening is doing, there are several ways in which we can do that. The gold standard, as is often the case in epidemiology, are randomized clinical trials in which we randomize some people to screening and other people to no screening, and then we assess in those two groups the outcome of interest. And if the screening is intended to prevent breast cancer mortality, the outcome of interest is breast cancer mortality. We can also do observational epidemiologic studies, including cohort studies and case control studies. And in these studies, the exposure and the outcome are the same as in the randomized trials, but we have all the standard problems of observational studies, particularly confounding.
And presumably observational studies are mainly useful when a screening test or screening procedure has been around for a while.
Well, in fact, that's exactly right. First of all, you can't do observational studies of screening until a screening program is being used. And generally, they make sense to do once the screening program has been in place for a while, as you just said. Once that is the case, you've got some people being screened, other people not being screened, and then you can take advantage of that and compare outcomes in the screened and unscreened population in a cohort study, or look at the frequency of screening in cases and controls in a case control study. Mm-hmm. So those are the two primary observational study designs we use. But also we can look at ecologic data and ecologic studies in a way to look at the impact of screening. So we can look at time series analysis to look at trends over time in mortality from a condition. We can make cross-national comparisons or things of that kind to see if the screening program is having the desired impact.
Right. And I understand that some of these observational studies have some particular biases. Some are particular to evaluating screening programs. Could you talk a bit about those?
Sure. So there are really three types of bias that are important for anyone to think about when they're thinking about how to evaluate the effectiveness of a screening program. And actually, these are potential biases not just in observational studies, but even in randomized clinical trials. Confounding is done away with by the randomization, but these three types of bias don't disappear because of the randomization. So these three types of bias to be familiar with, the first one is basically a form of selection bias. And so for students who've already studied different types of information and selection bias, this is basically a form of volunteer bias. That is, the people who agree to be in studies are different from the people who don't agree to be in studies. And that's true in every aspect of epidemiology. So there is the self-selection bias. In theory, that can bias the results of a study of screening either way. The two types of bias that are uniquely relevant to studies of screening are called lead time bias and length bias. Both of these types of bias will make screening look better than it really is if the comparison you are making is duration of survival after diagnosis, which is something people like to measure. So if you take women whose breast cancer was diagnosed through screening and compare them to women whose breast cancer was diagnosed as a result of symptoms, and say the duration of survival is different in one group from the other, then these two types of biases come into play, and both of them would make screening look better than it is. Now, I'm going to explain what those two types of bias are. Again, selection bias, again, is fundamentally the problem that people who agree to be in studies or to participate or to be screened or whatever are just on average healthier people, and they're not representative of the people who don't agree to be in studies. But to illustrate the issue of lead time bias, I'll take back to a timeline here. And on this timeline, we don't have one woman, we have two women. And both of these women in this hypothetical situation have the biological onset of breast cancer at age 35. So within each of them, within a breast, there is the development of biological breast cancer. Both women would have their breast cancer detectable by screening at age 40, but only woman A ends up being screened. And she's screened at age 40. Woman B is never screened, but woman B develops symptoms of breast cancer at age 43. Both women in this hypothetical example die of their breast cancer at age 46. Well, if you take a look at this and you say, how long did woman A survive following the diagnosis of her breast cancer? She survived for 5 years. She was detected at age 41. She died at age 46. Her survival was 5 years. Woman B had her breast cancer diagnosed when she developed symptoms at 43. She died at 46. Her breast cancer survival was 3 years. But in fact, if you look at this, you'll see there was no effective screening whatsoever. The diagnosis was made earlier. The woman survived longer following diagnosis, but there's really been no fundamental change in the biological process here. So this is what we refer to as lead time bias. And it's one of the reasons why comparing length of survival between screened and unscreened individuals is fraught with danger of overestimating the impact of a screening program. And that's also illustrated, then this is the illustration of length time bias, the other type of bias. And here the basic issue is that if you have some tumors that grow quickly and are very aggressive, you have other tumors that are indolent and slow growing and less aggressive, on average, the tumors detected by screening will be more indolent and slower growing than those detected simply by the onset of symptoms. So again, comparing length of survival or amount of morbidity or treatment costs or things between those two groups is affected by this type of bias as well. Now, this type of bias we can do something about to a certain extent, because if we have information about the tumor type, about the presence of metastases, about the level of aggressiveness of the tumor, we can potentially control for that when we make these comparisons, something we can't do for lead time bias. But the bottom line is, this is the reason why comparing the length of survival between screened and unscreened individuals may not give us, in general, doesn't give us a really accurate estimate of the effect of screening. What we really need are studies showing a reduction in the outcome of interest, so breast cancer mortality, cervical cancer or cervical cancer mortality, lung cancer mortality, not length of survival following diagnosis.
It's a very important point that we should always remember that we're looking for differences in mortality among the screened and the unscreened populations. So thank you very much, Art. We really appreciate your time talking to us today, and it's been extremely useful. Thank you.
Thank you.
And thank you all for joining us.